Okay. Good morning, everybody. Welcome to this session on indirect calorimetry, sponsored by ISICEM and GE Healthcare. And it's a great honor for me to introduce my co-host, Horst Brünner. He's an anesthesiologist from Fritzlar in Germany. And I'm from Ede and Wageningen in the Netherlands. Difficult names for you to pronounce, but it's not essential. But both of us are very experienced in the application of indirect calorimetry in critically ill patients. So that's the reason that we have been asked to do this session for you. So, and we wanted to make it very interactive. So if you have any question, just stop us and we were happy to answer your questions. Oh, here are my disclosures. So all the companies involved in nutrition and metabolism, and this is a sponsored session by GE Healthcare. So Horst will first start with presenting a case. Please.
Good morning, everybody. This is the calorimetry of a patient, 73 years old. He has a complicated cholecystectomy with an open abdomen approach for about 38 days. At this time, I put out the cannula of this patient on Friday on day 60. But we have here the calorimetry and the administered energy in this patient. And it is very interesting that we have a few days. We see more than 4,000 kilocalories on he needed in these days.
So Horst, the red lines is what you have measured with the indirect calorimetry,
and the green
is what you have given to the patient.
Yes. Yeah. Sometimes you see an overshoot. This was a communication problem with our nurses, and but I think in the most times we get the goal to get him the energy he needed.
Yeah. What is your conclusion when you see this for yourself, when you prescribe energy, kcals, to your patients? What is it? What kind of conclusion when you see this is the individual patient course of a single patient in ICU? So how do you prescribe your energy to the patient? What is your typical way of doing that? Anybody? Nothing is wrong during this session. What happens in Brussels stays in Brussels. We don't tell. Anybody? Or you don't give feeding at all? Yeah? So yes, please.
20 kilos for the first week and 25 after the first.
Okay. An equation, 20 kilocalories per kg of body weight. Okay, let's say this patient is 100 kilo, then you would give 2000 kcals. Very simple. But then you would do this. That's 2000. And you see the course of the patient is rather bumpy over time. Why? Why should it be higher here maybe? Any idea? Exercising could be. Was the patient already exercising here, Horst?
Yes, but he has several surgeries during this time, and I think he was in a septical situation at this time. And you see at the end of the period, here was a steady state. And we have a great part of enteral nutrition. Until this point of time, we have only parenteral nutrition in this patient.
Yeah, so the energy delivery can be both enteral or parenteral, or a combination. But we know now, and I come back to that later, that probably overfeeding more than the resting energy expenditure of a patient is negative for the outcome of a patient. So that's important to notice. And I must say, we see this kind of patients very often, that there is no straight line for energy expenditure. And using an equation, then you have a problem. what it also tells us that this is continuous monitoring. We have intermittent monitoring. We do it every 3 days, but he has the advantage of having this device. It's connected to the ventilator, the module, so you have all the data online. So do you use this technique also to predict other things than nutrition? Is it helpful for other medical issues?
Yes, when we are in the weaning process, I change more fat, for example, to produce less carbon dioxide to promote the weaning process in this patient.
Yeah, we come back to that later. You can impact the RQ, the respiratory quotient, by the substrates maybe you give to the patient. So that's one way. Another one could be, you talked about septic episodes. Sometimes you already see on a continuous monitor that the energy expenditure goes up before the patients become febrile or having clinical signs of sepsis. So it can also be an early indicator that something is wrong with your patient when the energy expenditure goes up. Of course, you can also see the effect of waking up. When you stop your sedation, you gradually see an increase. The same is for muscle relaxants. We did a study on that. When you stop continuous muscle relaxation, so neuromuscular blocking agent, you can see an increase of 6% of energy expenditure. It's not so much, but you can see all these things when you have continuous monitoring. So we go to the next. So you can take a look after the session to this device, and you can see here you have all this nice continuous interpretation. So this is graphical, a clear demonstration of the nutritional data. And you can also have a tabular view. So then you have the numbers, also for scientific reasons or so. You can know exactly what it is. So I think there are some advantages of having continuous monitoring. Of course, it also reduces the workload of the nurses because the device is running all the time. Now, I must disclose that I think we are maybe fans of indirect calorimetry. So we are believers. So that's a disclaimer. And this is one of my PhD candidates who did a lot of work on this. And why I work at this university is very famous for agriculture and human nutrition. But we try to bring all this knowledge to the bedside, and I think that's important. What are we going to do with this? So during this session we want to help you a little bit. How can you use indirect calorimetry in your daily practice? So it should be interactive. Now, how does indirect calorimetry work? Anybody? How can we use this device to predict the energy expenditure? What is the technique? Okay, something with VO2 and VCO2. Can you help us, Horst? What is it about?
We are measuring the consumption of oxygen and the producing of CO2. And so we have this formula, and with this formula and the measurement of these two parameters, we can calculate the energy expenditure over the time.
Yeah, what is very important, the wire equation uses 3.9 times the oxygen consumption and 1.1 times the CO2 production. So some mechanical ventilators in your ICU have VCO2 available in the device. So that can also help you to predict energy expenditure. Then it's VCO2 times 8.2, that's 24 hours kcals, but then you assume a normal respiratory quotient because you don't have the VO2. And you can see here the error must be large because this is times 4. So you only know this one. And that's probably why indirect calorimetry is much better, because then you have both. And that's essential. So the VCO2 is maybe better than equations, but it's not the whole story. It's better to have full indirect calorimetry. Okay, this is how you can do. And the four most important readings are VO2, VCO2, RQ. What is RQ? Respiratory, that's VCO2 divided by VO2. And the resting energy expended. That's the kcals per 24 hours. So, and we put in the Aspen guidelines that, well, indirect calorimetry is something an ICU patients can expect you to use, because we think it's important to measure it. Now, one of the difficult issues we want to discuss, when you have a reading of the device and it tells you 1900 kcals, should you give 1900? When do you have to give this, or more or less? Any ideas? Are there situations that you would give less calories than what the device would predict?
First days or acute phase of disease?
Acute phase. Horst, do you always give what you measure, or maybe in certain situations you go higher or lower?
At the beginning of a case, I give less.
In the beginning, we give less. Okay.
For about 24 to 48 hours, but I never give more than.
Never give more than what you measure.
Never give more than we are measured.
So there's people because, well, energy expenditure can vary a lot. Here you see many reasons why it can be higher or lower, and the net effect of all these factors in your patient will be difficult to predict. So it's inflammation minus sedation plus something else, so it will be difficult. So it's, I think, impossible to predict. We try to do it at the bedside. We ask the nurses or the doctors, what do you think? Is this patient higher than 2000 kcals or lower? Nobody can predict. It's very difficult to know. So, and the same is for the equations. Now I want to one thing, if you take a publication on indirect calorimetry and the equations, and you take 2000 patients each, the average is exactly the same. So you could say, why use indirect calorimetry? Because equations are based on indirect calorimetry. So the average is always the same. But the problem is in the individual differences among the patients in the population that have, so, and they're static, so it's always the same. And you've seen that the variation is very huge, you know? So it's not very helpful. Now we know in the first week we have to give slightly less than what we measure with indirect calorimetry. And this is due to the endogenous energy production. And overfeeding is associated with increased mortality. So 10% more than measured energy expenditure is dangerous already. So when you measure 1500 kcals, in the first days you would give 1500, you have this endogenous energy production. That's the catabolic response. So patients produce a lot of glucose from glycogen, they break down lipids and amino acids, so there is a lot of energy. And this is non-inhibitable. So normally when you give feeding, you will stop breaking down your stores. But ICU patients keep on breaking down the stores. That's catabolism. So when you give the full dose, what you measure, it's overfeeding. So what you better can do is this. Start with a low dose of feeding and then gradually progress to the target. That's also in the guidelines. So you can measure on day one, but you should not give the full dose measured on day one. You have to wait a few days. Okay, so this is what we recommend now, to go slowly to the target. So we even use an equation in the first few days, and then we readjust our target based on indirect calorimetry around day 3-4. If you have it continuously, you have it already present for your patient. So that's... Now another issue is caloric restriction during refeeding syndrome. So when a patient has a drop in phosphate, you have refeeding syndrome, you should not follow the device, but you should restrict the calories. So that's important. So not always follow indirect calorimetry. You have to understand metabolism. So caloric restriction in refeeding hypophosphatemia is essential for 48 hours, and then you can gradually progress to the target again. And then, of course, we have the different phases. This publication I did with Elisabeth de Waal and Paul Wishmer. So the first few days go slow. Then you go to the target, and when the patient is recovering, you have to increase. And in the late phase, maybe you can go over what you measure, because you have to recover, you have to to build up new tissue, then maybe slightly higher than the energy expenditure is acceptable, but not in the acute phase. Okay? Now let's move on. So there are some reasons not to follow the indirect calorimetry in the first few days, during refeeding hypophosphatemia, during recovery, and of course when exercise-induced energy expenditure is substantial. Because you measure in rest when the patient is in the bed. When you start exercising, there's more energy expenditure, of course. Now, how can we help to reduce infections by doing this? Any idea? Well, that's a difficult one. But we know, for instance, that if you look at parenteral nutrition, there can be a higher risk of infections. But we found that the higher risk is only driven by the patients giving more calories by PN than by EN. When the EN-PN dose is the same, there's no increase in infection. So it's not the PN, it's the dose we give with PN. So if you prevent overfeeding, you may reduce your infection morbidity in the ICU. And there's also some data showing that it can reduce even mortality in patients when you summarize all the data in a meta-analysis. So here you can see that if you use equations and you measure indirect calorimetry, you have a large proportion with all the equations of overfeeding and underfeeding. So the equations are not very helpful. So of course you have to also do the investments in the device, but you will probably earn also some money, and this is work done in Brussels, and they try to calculate what are the costs and the incidence of the effect of under and overfeeding, and it saved days in the ICU and the hospital, reduced the number of infections, and by doing this you save some money. So that's the money you can use for investing in the device and also the disposables, because some people say, well, it's an expensive device. It's not expensive. The device is not expensive, and you use it for 10 years or so. So we do so many things in the ICU that are much more costly, but it can reduce morbidity. So this is a calculation of the cost reduction in several countries when you use this kind of intervention like indirect calorimetry. Everywhere it saves money. So I think it's a good idea to do. Now, what is RQ? We discussed this. What is RQ, Horst?
It's the division of CO2 production and oxygen consumption. And with the IQ, we can drive our patient to more activity in kind of weaning. And you can interpret what he is using. Is he using fat, or is he using glucose, for example? And or is he using proteins for his energy consumption?
So in the lower part of this slide you can see that the RQ is a total, is a mix, is a combination from the substrate burning. So when you burn like fat, you get an RQ of 0.7, proteins 0.8, carbohydrates 1.0, and I've also added citrate, what you use in dialysis patients sometimes. It's 1.33. So the total is of course a mix of what you give to the patient. Some people call that the food quotient. We have a very sophisticated system. We can calculate all the intake from nutrition, from non-intentional, and then you can know, I give so much grams of this and so many propofol, and you can calculate what you give. And then you can calculate what should be the RQ, and we call that the food quotient. So that's the combination of all the ingredients you give to the patient. But there is a problem. The food quotient does not reflect the RQ of the patient. So in you it can. When you eat, your RQ will mimic what you eat. When you have a high carbohydrate loading, it will go up. In ICU patients, it's not the case. Why? Because they're catabolic. They break down the tissues, although we give a different composition as feeding. So that's also the reason why you cannot use the VCO2 very well, because the RQ is not the population average of 0.86. Sometimes it's higher, sometimes it's lower, so you don't know. Now, what are the pros and cons? And I've summarized some of them here. When do you not use the readings of indirect calorimetry? Are there situations in the patients like you won't do it? What do you do with PEEP? You always use it?
Yes.
Yeah. There are some ideas that maybe over 12 PEEP the readings are not completely reliable. The same holds for very high FiO2. And that's because of the VO2. So the VO2 is measured by FiO2, what goes into the patient, what comes back to the patient. So when you have 0.40 FiO2, what comes back is 0.396. So very small difference the device has to calculate. When you go to a FiO2 of 0.9, what comes back is 0.899 or something. So it will be very difficult to see the difference. For CO2, that's not a problem, because the CO2 inspired is very low and what comes out is very high. So this difference is much easier to calculate.
The device is not working with the FiO2 over 80%.
80%, yeah. Most of the devices between 0.7, 0.8 you cannot use. So then maybe you should use the VCO2 only or an equation. And when you lose air, so what about the chest drain when you remove fluids from the chest? Can we use indirect calorimetry then? No? Everybody agree we cannot use? If it's fluids, there's no problem. When there is a fistula and you have leakage of air, then you have a problem. So all the air should go through the endotracheal tube. So when there is air leak or you use like a tracheostomy and it's leaking, or you're not cuffed, then you have a problem. You cannot measure. So if you consider, is all my gas going through the endotracheal tube or through the cannula, there's no problem. And a chest drain, so sometimes when nurses say, well, there is a chest drain, we cannot measure. But it's for fluid, no problem. Okay? And, well, we know now, we said conditions requiring adjustments during CVVH. That was done in Brussels by Joop Jonk here. There's only 1% difference. So you can just measure during CVVH. During ECMO it's very complex, but we have equations to do it. It's possible. So in most conditions in the ICU, I think in a study we did, over 95% of the patients could have all their measurements performed. So you don't have the contraindication. Yeah? So we discussed this before. Yes, please.
Do you have any data on patients under inhaled sedation like sevoflurane? Like, I don't know if you use it, but can you use indirect calorimetry for these patients?
Do you know that?
Yes, we use it with isoflurane, with this module, and it works very good.
Okay. Can be done. Also no contraindication then. Eh? This is what I told about when you have a ventilator with only VCO2, you can use it, and it's maybe better than the equations. This was studied in Amsterdam, but we also did a study and we found that it's not very helpful. So you have to estimate the VO2, and the VO2 can be estimated by the VCO2 divided by RQ. And then we have to estimate RQ because we cannot measure. So then we fill in the average of the population. But in real life, it's higher or lower in ICU patients. So that's the reason why it's inaccurate. So we tested this in a study that the dream of the VCO2 technique is maybe not a very good dream because it's not so very reliable. And that is what you can see here. So we see a difference in prediction of energy expenditure. There was a set-off of 500 overestimation of energy expenditure you have to give. So that's already dangerous to give 500 too high. But also the variation is 500 more or less. So you cannot use that in the patient because you go over this threshold of 10% overfeeding. So there is a risk in some of the individual patients. So before we close the session, Are there any questions to Horst and me about indirect calorimetry? Yes, please.
So when you do indirect calorimetry in very obese patients, like BMI over 40, it often gives a very high number, like almost 3,000 calories. So how do you manage that? Do you give the amount of the REE or do you give less?
Well, that's a good question. What do you do in the audience? Do you give like 3,000 kcals in an obese patient when it's measured, or you give a lower dose? Who is giving the same? Who's giving lower? Most of you give lower. Well, we don't know, because no studies have been performed. But I think when you give a lower dose, you will use probably more proteins for energy. There is a very elegant study from Stockholm showing when you reduce the energy intake, the amount of proteins from muscle that are oxidized for energy increases. And maybe not when it's 10%, but when you go to like 50%, you see a huge increase in the use of proteins as energy source. So we give it, but we will measure frequently to be sure that maybe not 2 days later it's like 2,500 and that we are overfeeding 500 kcals in this patient. But I think it can be rather safe to give this high energy expenditures. And during COVID, we've seen very high values during the recovery in the second week, sometimes 3,500 kcals in patients. And when you use an equation predicting 2,000, you're having a deficit of 1,500 kcals. So that's interesting. More questions, please.
A question not really about indirect calorimetry, but how do you offer a patient 5,000 calories? How do you offer them 5,000 calories with parenteral nutrition?
Not only with parenteral nutrition at all. We have a mix of enteral and parenteral nutrition. And so you can reach the goal of 4,500 kilocalories in this patient.
Well, I think it's very rare. It can happen. What I do is I measure the RQ in the patient. It's available from the device. And I always watch the reading. Sometimes you have an RQ of 0.49. What does it tell you?
The patient needs glucose.
But is it possible based on the substrates you've seen? Can you have 0.49? It's very low. So, or you have 1.67. So there could be something wrong. Sometimes you have misreadings of the device. We have another device than this because we do intermittently. Sometimes is humidity in the system. You also can have erroneous measurements. So first I check, could it be in this patient? So were the previous readings also very high, like 4,500? Then it could be true. But when it was like 1,500, 5,000, you have to check, is that really a good measurement? Because there can be some technical issues. That's also important to follow your gut feeling, if it's okay.
Two questions. One, why PEEP more than 12 is a contraindication for using indirect calorimetry? And second one is if there is any way to assess if my nutrition is utilized, because what I'm measuring is not really, I don't know what I have to do, what I have to give, because sometimes the patient is not able to utilize. So is there any way to understand by indirect calorimetry this topic?
Give a short answer for the second part. I have a lecture 12:30 in the Nestlé Lunch Symposium. I will address this. So what is the metabolic fate of the nutrients? And that's another question. The first question was about PEEP.
I think it works with PEEP over 12. We use higher PEEPs in our department, up to 20, and it works very good. And it's not only the indirect calorimetry we need to compose the nutrition. We also look for laboratory parameters for blood glucose, insulin consumption, and things like this. And so we have a lot of parts for composition of nutrition in our patients.
Yeah, the idea is probably that you compress the volume and that it may lead to, well, differences in the measurement technique in the device. But I hear more and more that intensivists go to 14, sometimes 16, and that don't see major differences in the readings. I think a very high FiO2 is more a problem, because then it becomes very difficult for the device to measure it. I think we're maybe the last question, and then we have to stop the session.
And what about VO2 per 7 times VO2 formula for estimation without indirect calorimetry?
Can you use VO2? Yes, when you have it available, it is probably more helpful than to have only the VCO2. But when you have only the VO2, you don't have the VCO2, but it's only times 1. But we don't have any device that can measure continuously or the VO2 of your patient. If you have such a device, it can also be used for predicting energy expenditure. Yes. I don't know. Also, maybe the same problems with very high FiO2s will be the same, I think. But I have no experience with only VO2 monitoring, only with indirect calorimetry. Okay, we are at the end of the session. We will be here. If you have additional questions, come to Horst and me. And thank you for attending here, and GE and ISICEM for making this possible. Thank you very much.